Thank you everyone for joining us for the influenza webinar today. Before I start, I just want to say that I hope by the end of the webinar today you'll think that the flu virus is as interesting as I do. I have to say it's one of my favorites. It's a pretty clever virus, and I hope I'll be able to describe for you a bit more than you may know now, and to give you an appreciation for just how interesting flu can be. So today we're going to talk a lot about the biology of these viruses. There's a lot of different influenza viruses that cause a very similar disease. We're going to talk about the public health importance of influenza. We're going to discuss transmission and exposure risk, and also best practice for exposure prevention to employees. So influenza virus, there are basically 4 types. There are several that we don't hear a lot about in the news. Those would be type C and D. Influenza type A, though, we hear a lot about. This virus will infect humans, can also infect horses, but mainly will infect avian species and also swine. And so we're going to talk more in depth in a couple of slides as to why that is important. But the avian A virus is the one that is multi-species, or I'm sorry, influenza virus. Influenza virus B affects only humans, but it can cause pandemics. Influenza virus C is usually very mild presentation, and so you don't see this causing really serious disease. And type D really only causes disease in cattle, and it is not believed to cause any disease in humans. All influenza viruses are categorized by 2 different proteins that are on the surface of the flu virus. So this is a schematic of the influenza virus, and there's 2 different proteins that you've heard of. One is the hemagglutinin and one is neuraminidase. And so there are 18 different hemagglutinin and 11 different neuraminidase for the different flu viruses. And we're going to talk a bit more about what those do in a little bit, but that's how they're going to be categorized. So you probably heard of H1N1, and so that's where that notation comes from. The hemagglutinin is really important because it actually binds to the cell that the influenza virus wants to infect. And so even though there's 18 hemagglutinins for, let's say, influenza A, the hemagglutinin is going to be different for those viruses that target humans, those that target avian, and those that target swine. They bind to something called the sialic acid on the membranes of the human cells. And humans have a different type of sialic acid receptor than avians do. The swine happen to have the sialic receptors that both humans and avians do. And so we're going to talk more about the role of the swine later, but they consider the swine to be really integral in how viruses will jump between species. The neuraminidase protein is important for the release of the virus from the host cell, so that way it can go and target additional cells. So the HA is for binding and infecting, and the neuraminidase is for release. Influenza is an RNA virus. It has an envelope. The really important thing about flu, though, is the segmented genome. The segmented genome allows it to do a lot of the reassorting that we're going to talk about later. So this is a schematic of the genetics of influenza virus. There are 8 different genes in influenza. They're listed here, sort of as a very rudimentary drawing. These genes, and because they're in a segmented way, can easily be shared between different influenza viruses. This is where we get different pandemic strains, and I'll explain that more in detail in a few slides. The different genes, we're really going to just focus on 3 today. I've already described the HA and the NA, but I'm also going to describe M. M is a channel protein, which is also on the surface of the influenza virus. So you can see here it's in purple on the first slide. There's only a few of them. This channel protein changes the pH of the membrane and helps to allow for unpackaging of the viral genome during infection. And so later on we're going to talk about antivirals. But without a proper M protein, you're not going to have the virus be able to unpackage and start replicating within the host cell. Influenza virus nomenclature can be sort of lengthy, really. So I've put a couple of notations here for you. Influenza A viruses are always grouped into subtypes, H1N1, H3N2. Those are the ones we hear the most about. And then when you look at the strain though, as you can see on the slide, it's going to be pretty detailed. So it's going to have whether it's an A, A is the A virus. It's going to have the species, so it was found in duck, the location or strain, so Alberta, this is the strain number, 35, and then the year is 76. And then influenza viruses, the A types always have what the HN categorization is at the end. Influenza B viruses are a bit different. They typically fall into lineages. They don't tend to go into subtypes, and so they typically follow two lineages, either the Yamagata or the Victoria lineage. So there are a few different variants of influenza virus infection. So we mainly are hearing of avian influenza, human influenza, and swine influenza. And so you may hear on the news about swine flu. The last outbreak in that was like 2011. We sometimes hear of pockets of avian influenza. So I just wanted to show this schematic to show you how these different viruses and the segmented genome will recombine to form a virus that's different and that's reassorted and that can become an issue for humans. And we're going to talk about it a few different ways. So you can see on this slide you have one gene coming from a domestic duck, which was an H7N3 virus. Then you have another gene coming from an H7N9 virus, which these are typically low pathogenic type of viruses. And then you have a domestic poultry supplying another set of genes. So then you get a recombinant virus here that's going to be different and more able to infect different species of birds. When these viruses jump from birds to humans, they tend to have multiple mutation events, but also it's usually only in people who have very detailed work with avian species. And so the pockets of infections that we see with avian influenza tend to be with people who are working in poultry farms or maybe in slaughterhouses that may be coming into contact with infected birds. And the only way to deal with infected birds is really to cull the flock. And so this kind of change in influenza viruses, there's different types of antigenic changes. And so the different genes in influenza, specifically the HA, will mutate slightly and change how it binds to the cells. And so if you have something called antigenic drift, you have small changes in the viral genome. So these just happens over time as the virus infects cells. You're going to have slight little mutations just in order to keep the virus in a state of good fitness, so that way it continue to infect and our immune system does not necessarily remember it. So this is the schematic on the left. So you can see the first virus has one kind of antigen on its cell surface, but then over time it's going to slightly change so that way it can still bind the whole cell. There's not any major changes, but that our immune system doesn't remember and can easily infect and propagate. Then we also see something called antigenic shift. And so the antigenic shift is where you have more of a reassortant situation. So the schematic here on the right shows 3 different types of influenza viruses with 3 different types of antigens on the host cell. What happens is the genes from these viruses will combine into one new flu virus and create a virus with multiple different antigens. This virus is something that's going to be completely unknown to our immune system and is going to affect many more people around the world than would normally be affected by influenza infection. And so it's important when we talk about pandemics to understand that antigenic shifts, where you have a reassortant of multiple different influenza viruses, will cause those sorts of infections, versus the antigenic drift, which leads to more isolated epidemic situations. And so here's a nice schematic from the CDC showing the reassortant of multiple different flu viruses. So in each of the viruses that's shown here, the purple is human origin HA and NA, so hemagglutinin neuraminidase. So these are things that are human origin, but they're antigenically different than what is currently circulating. So we always have currently circulating flu viruses, but these are genes that are slightly different from what we see currently circulating. The blue would be a human PB1 gene. The green genes are from avian origins in North America. The yellow is a swine origin, and that's from North America. And then the red is swine from Eurasia. And so you can see on the left, we have different swine H3N2 viruses from 1998 to 2011 that have one type of composition. The one thing they differ in is the M protein. In the middle, you have the 2011 virus that caused a decent number of cases in Indiana and Pennsylvania. And again, this was where the swine was sort of mixed all these viruses together, and you have a completely new virus. The pandemic strain shared only one gene with this 2011 strain, and it had a whole different number of HA and NA genes from swine in both North America and Eurasia. And so the way this works is that the swine, because pigs come into contact with both birds and humans, and because they have the receptors for both human and bird flu strains, what researchers think happens is that you can have more than one virus within the pig. And so it's a really good mixing vessel for new and pandemic strains, because you have the ability for multiple viruses to infect cells, and then as those cells replicate and repackage, the virus will pull different pieces of DNA. As long as it has one gene for each protein that it needs to have in order to be a full virus particle, it doesn't care necessarily if that was a human origin gene or an avian origin gene or a swine origin. And so then you get these pandemic strains. And so the pandemic 2009 strain for H1N1 happened to be a very new strain. And the reason why it caused such infection was that nobody had any immunity to it. And it had a completely different makeup than strains that we had previously seen. So just to switch gears a little from the biology of influenza viruses, let's talk about some symptoms. So symptoms of flu are very vague. A lot of diseases that we know of cause flu-like illness. And so when we say flu-like illness, typically we usually mean fever or having feverish type feelings and chills, cough, sore throat, runny nose, achy, tired, headaches, sometimes vomiting and diarrhea, but that's mainly seen in children. It's important to note that the symptoms can vary on different strains, and each person may have a slightly different response. And so I know I always ask this question, right? Especially during what they call flu season. Do I have the flu or do I have a cold? Meaning, and that usually informs my decision of whether or not I should go to the doctor. And so if you look at the chart here, there are some common overlaps, but there are some differences. So if you have a cold, you're not likely to have a fever, you don't have as severe aches and chills. You sometimes also may have not as severe of weakness and fatigue. You will, however, have more sneezing, stuffy nose, and sore throat with a cold than you will with influenza. You sometimes will have, the common symptoms, are really more of like a cough, and the headache can also vary. The symptom onset, though, with a cold is going to be gradual. Like sometimes you might wake up, your throat is going to hurt a little bit, and then over the next couple of days, your symptoms are going to get worse. With influenza, however, you pretty much wake up and you feel terrible, or the symptoms just come on all very suddenly. And really the only way to tell the difference is to go and be tested. So influenza is pretty transmissible. The infectious dose is actually not known, but is thought to be pretty low. Researchers find in animal models that aerosol infection has a lower infectious dose and has a greater chance of causing disease than droplet infection. So that's something to keep in mind that we'll talk about at the end. Droplets can travel up to 6 feet in distance. And so even if you're more than or around 6 feet away from somebody, you could still come into contact with droplets that could make you sick. And again, this is always something that's an issue for mucous membrane exposure, inhalation, and also surfaces. So at the end, we'll talk about disinfectants, but influenza virus can live on non-porous surfaces for 24 to 48 hours, and on surfaces like Kleenexes and cloths for approximately 12 hours. And so it's really important to not come into contact with those kinds of materials, because that can also lead to disease transmission. The other tricky thing is that people are shedding virus and infectious one day before they have any symptoms, and once symptoms start for 5 to 7 days. So just like with everything, it's really important that if somebody's having severe symptoms, that they stay home and they limit their contact, so that way they limit the number of people that become sick. So influenza every year has quite the run. Some years, I'll show you a slide in a second, where some years flu season starts earlier and sometimes drags out. Sometimes there's very limited time window. It really depends on the viruses that are circulating. And so this is a schematic from the CDC for last year showing the predominant strains that they saw during the typing. So it's important to keep in mind when we're talking about the public health impact that this is only for people who went to see a doctor and actually had a flu test done. So some people may have influenza and they do not seek medical treatment, and so you don't know if you actually have the flu. And so the number of cases of influenza could likely be underreported due to this fact. So based on last year, it looks like the H3N2 variant was the strain that was most likely to be seen. And the flu season starts at week 48, so right in sort of the end of December, and then starts to peak as we get through January and early February, and then starts to taper down again. And so this is really important too to keep in mind when we talk about the vaccinations, is that the timing of the flu season and when it starts is when people should time their vaccination. You can see there is a small population of people who had the B strain lineage, which is more of the greens. All of the A's are in the reds and the oranges. So this schematic is just showing you over the past 7 years the number of visits to medical facilities for influenza-like illness, as reported, as influenza is a reportable disease. And so you can see there's one outlier in 2009 where flu season started really early. It started at week 40. So this was a really early season and very uncommon. This was also when it's good to put some distance between symptomatic persons, especially if you're in a waiting room or an emergency room. It may not always be feasible, but putting distance between people and putting a surgical mask on a patient is a good way to decrease any likelihood of further infections. I know on an aside, there's certain doctors' offices that will actually have rooms for people who have respiratory symptoms versus the rest of the population, to try to help segregate out and prevent infections to people who are not sick. It's important also to understand when to wear a respirator with influenza. Influenza is able to be transmitted through aerosol. If you have a patient in a surgical mask, it's a less likely of an issue because the surgical mask will help with droplet precautions and the sneezing. However, there's always the concern in certain areas for avian or swine influenza. And so if the person had been working with, and it's not so bad in New Jersey, right? But in certain areas, if the person had been working on a poultry farm, for instance, and they came in with flu-like symptoms, it's really important that the healthcare worker be wearing a respirator, just in case that virus is avian influenza and it could jump between person to person. It is unlikely for avian influenza viruses to jump and cause pandemics, although that is a big fear of public health professionals. But for the most part, avian influenza viruses tend to only do maybe 3 jumps within people before they peter out, just because they're not ideally suited for human infection. If any kind of aerosol generating procedures to be done on a patient, like intubation, suctioning, that kind of thing, they need to be wearing, the worker should be wearing a respirator to protect against aerosols for any of the influenza viruses. And then also disinfectants. So if somebody is in a room and the room is thought to be contaminated, A wipe down with appropriate disinfectant is suitable. Influenza is susceptible to a wide variety of disinfectants. The EPA does have a listing on their website for influenza effective disinfectants, although bleach, a 1 to 10 dilution, is really sufficient. Also things like Lysol and that kind of thing are effective against flu viruses. And so let's talk about the flu vaccine. So there's a lot of different formulations. I'll spend a little more time on that in the next slide. But basically, they're recommended for persons more than 6 months of age, and there are rare exceptions. And as they increase the amount of formulations of flu vaccine, those exceptions are decreasing. The flu virus vaccines are a mixture of influenza A and B vaccinations. Right now, they have two main kinds, the quadrivalent and the trivalent. And so the trivalent is 2 influenza A viruses and 1 influenza B virus. And the timing of vaccination is really important. And so if we look back a couple of slides to when we saw influenza positive tests occur, we see them, December, late November. That's right around the time people are realizing they haven't had their flu shot. And so flu shots start to be advertised in September or October. That is when you should get your flu shot. You need at least 2 weeks after vaccination to have immunity to influenza. And so if you get your flu shot in January, it may not be effective because you may have already been exposed to influenza. And it depends really when the peak time is. So the best time to get your flu shot is in the fall, before flu season starts to spike, and before we all get wrapped up into the holidays and forget to get our vaccination. So a little bit more on the flu vaccine. So the trivalent and the quadrivalent have, multiple formulations. Right now, the most common vaccine on the market is the inactivated vaccine. This is a killed virus, so it cannot cause infection. It's recommended for all ages, 6 months and higher, and there are multiple formulations. So for the most part, most people are going to receive like the basic formulation. It's, sometimes you can choose between the trivalent or the quadrivalent. If you're worried about influenza B, it's good to get the quadrivalent since there's 2 viruses in that formulation. But it's always good to ask your healthcare provider which vaccine they're providing you. It's amazing to me how many times I'll ask people, when they say they got their flu virus vaccine and they don't even know what they received. There's a very standard dose of these vaccinations. Most of the time they're grown in eggs and then they're purified. So that's why they have some concerns about people with egg allergies, but there are other formulations, and the CDC has lifted most of the restrictions against egg allergy persons from receiving the vaccination. And so it's important to talk to your healthcare provider about that. There's different shots for different age groups. They might be slightly different in the antigen components. That's what it seems to be if you look up each of the different vaccines. There is a high dose inactivated vaccine that's used for people over the age of 65. This vaccination, has 4 times the amount of antigen as the regular vaccinations. And this is because as people age, your immune system becomes weaker and it needs more antigen to create the memory for the virus. There's also a cell-based vaccination. So this one is not grown in eggs, it's grown in cell culture. And so it helps for people who do have the egg allergy. And it's still, again, an inactivated vaccine. There's also a recombinant vaccine. This one is actually based on HA. It has a multiple array of HA from 4 different flu viruses. It's grown in insect cell lines, so everything is a cell line based recombinant vaccination. I don't believe this one's used as prevalently as the inactivated vaccine, but it is an option, especially for people who maybe have any of the contraindications to the inactivated vaccine. There is also an attenuated shot, so this is usually the nasal spray or flu mist. It was not used in 2016 because the group of experts that the CDC uses to inform on influenza vaccinations found that this formulation did not have a huge protection level over the past 5 years, and so they did not recommend it for the 2016 to 2017 vaccination season. it is an attenuated shot, and so it was only available to persons between the ages of 18 and 65 with healthy immune systems. And it's important, just I want to state it, that the influenza vaccine does not cause the flu. Most people are receiving an inactivated vaccine. It's a killed virus. It cannot cause the flu. Most people who get the flu from, or as they say, from the vaccine, it's because they received their vaccination so late that they probably were already exposed to the flu and they didn't have the full incubation time, or that the vaccine was not effective against the strain that they were exposed to. Remember, this is only 4 different strains of the flu virus, and sometimes the strain will mutate slightly and be different, or there could be strains circulating that the CDC doesn't anticipate, and so the vaccination may not cover those strains. However, it is really important, all of those things taken into account, to get vaccinated, especially if you're working in a healthcare setting. You will be exposed to people with influenza infection. Influenza is pretty transmissible, and so it's better to be vaccinated and to prevent infection as much as possible instead of just relying on luck. At least that's my opinion. And so let's say you get the flu and you're looking for an antiviral. So very similar to bacterial infections, some viral infections have drugs that you can take that will help to treat the infection. Unlike antibiotics, antivirals do not eliminate influenza infection. It will lessen the symptoms and potentially make the duration of illness shorter. There are some side effects. I'm not going to get into all of them because it depends on the population and the age, and it gets very complicated. But the important thing is that with these antiviral therapies, that you have to have a typing of your influenza virus, because some of these drugs, there is resistance found in the wild type influenza viruses that are circulating, and so depending on the virus and the subtype and also the origin, it may be resistant to one or more of these antivirals, and so taking it is not going to do anything for you, and it's only going to propagate antiviral resistance in these viruses. So that being said, the other caveat is that you can only start taking antiviral therapies, I believe, within 72 hours of symptoms, or 48 hours. And so if you start to have symptoms, you pretty much have to decide very quickly if you're going to take them, otherwise they're not effective. And so it's important to get a flu test if you think it's the flu, and to talk to your medical provider. There are 2 main kinds of antivirals. One targets the M2. So if you remember, M2 is a protein on the outer part of the virus envelope that helps the genome to unpackage. So this is part of the infection process, and without this protein active, you won't actually get the virus to package, and it will not be able to replicate. And so there's 2 here. This is amantadine and rimantadine. And so the rimantadine, though, is adults only. Children under the age of 18 cannot take this drug. Both of these drugs can be used for prophylaxis and treatment. So if somebody was exposed, you could use these as prophylaxis. Prophylaxis is usually only used when somebody might have been exposed to an avian only or a swine only variant of the flu virus. This is something that could occur or is thought for laboratory workers who are doing either research or diagnostics. Avian only viruses have a much higher level of safety required for their safe handling in the laboratory, and so it's important to have potential antivirals in case somebody was exposed. There are also neuraminidase inhibitors. So if you remember, neuraminidase is the protein that's responsible for the release of the virus from the host cell in order to go and infect other cells. These are ones that are probably more known to people. This is like the Tamiflu family of inhibitors, so zanamivir and oseltamivir. Oseltamivir is Tamiflu. It's available for treatment or prophylaxis. Anybody greater than 1 for treatment, but not prophylaxis, and then anyone over the age of 13 for either treatment or prophylaxis. Zanamivir is used only for treatment, and you have to be over the age of 7 in order to receive this antiviral therapy. And so it's important to, again, know the type of the virus that you have, if you have flu infection at all, before taking any one of these. And so with that, that's the end of our presentation today. I'm happy to take any questions that you may have. Looks like we have a bunch. Yes. Should someone who has a flu go to the doctor, or should they self-care? Well, I think that becomes a sort of a personal decision. If you have the flu, it's always good to go to a doctor, especially, depending on what your job is. If you are a healthy person and it's early on in your infection and you can take an antiviral and you don't have, it might be a good idea. If you have any kind of immunocompromising conditions that would make you more susceptible to complications like pneumonia, bronchitis, more severe complications, then yes, it's really important to go see a medical professional. But it really becomes a sort of a personal decision at that point. I think people sort of decide how sick they feel before they end up going to the doctor. It is important, I think, also when you are dealing with small children or the elderly, to go see a medical professional, as complications of flu infection can be more severe and they may need additional therapies like nebulizers and things like that. There are a few questions about the PowerPoints. They will be available. Would the quadrivalent be more effective for 65 and over? So the quadrivalent is available for the ages of 65 and over. It is all age ranges. I think the problem is necessarily that sometimes the shot people get is the shot that's available. And so, for example, my dad, he doesn't know that there's all these different formulations of the flu virus vaccine, and he tends to go to the drugstore to get his vaccine. And so sometimes if you're not sure what you're looking for, you may not know what to ask for. And so I think it's always nice to go, if possible, to a doctor's office, so that way you can discuss which formulation is best for you. The quadrivalent is very new. It's really only been out in wide circulation for about 2 years. So I think people are starting to get used to the fact that it is available. It is important, though, for people above the age of 65 to receive the shot with the higher dose of antigen, so that way their body does create a memory. Could you please discuss the risk and benefits of Tamiflu prophylaxis in a long-term care setting? Oof. I'm not a medical professional, so I'm not really comfortable discussing that. Although I will tell you that just like antibiotics, using antivirals for prophylaxis to prevent something is just not smart in terms of infectious disease and antibiotic resistance or antiviral resistance. The flu virus can mutate very quickly. There are already resistances found in these virus strains to known antivirals. There are not very many drugs that can help eliminate the symptoms. And when you use things prophylactically, there are always resistances that can develop from that. So, I'm not an infectious disease doc, so I'm not going to say any more on that, but that's just my opinion. Will flu mist be recommended this year? I don't know. The CDC does not have any guidance out for the coming influenza year. Right now, we're still a few months away from the start of flu season. I don't believe they've even released any flu vaccinations yet. And the CDC website hasn't been updated for any information for 2017 to 2018 flu season. But right now, they're just not recommending the flu mist or the attenuated vaccine at this time. I may have missed a self-care recommendation. Please review or summarize. So for self-care, really it's hydration and keeping your fever down. And if you have any additional complications, to see a medical professional. Complications from influenza can include pneumonia, bronchitis, severe breathing issues. So if you have an immunocompromising condition, you need to go to a doctor. Self-care really is clear fluids, so you don't get dehydrated, and a lot of rest. That's about it, unless you take an antiviral, but even then it may not always work. All right, I think I have gotten all the questions, so thank you all for logging in today. And there's another question coming in. No. Nope, that wasn't a question, so I'm going to log off now. Thank you so much, everyone.